Questions? Yes. Yeah.
I wonder if there's a premise here that is problematic in all this, and you assume that psychopathology is categorical, diagnoses are categorical, and that temperament is continuous or dimensional, so that you're implying that diagnosis involves discontinuity somehow in nature. But this is a discontinuity that comes from our diagnostic systems that are just based on clinical phenomenology and not etiology. I guess my question is there really any reason to think that psychopathology there is a discontinuity there, that it's anxiety disorders, for instance, are taxonic, because it sort of forces you into some implications that may be problematic. If you think about psychopathology as continuous, and you think about temperament or personality as continuous, it's probably a lot easier to overlay those one on the other.
Yeah, absolutely. I agree. Not quite sure how best to answer this. In coming into this, my assumptions, my background has always been to talk about psychopathology as, particularly anxiety, but psychopathology in general as being on a continuum. And so in trying to address this question, and Rob and I talked about this a bit, in trying to address this question, we were necessarily forced into a position where we talked about psychopathology, or at least anxiety disorder, as a category, because that was the only way to be able to identify the construct as it is described in the literature, because it's defined through diagnosis, and it's defined as a category in the way it's looked at in the literature. So I agree that as soon as you start, the problem is as soon as you start looking at it as a continuum, then it is almost by definition it's going to start to look exactly like temperament. Nevertheless, even people who argue that there is a continuum of psychopathology would still say that once you get to diagnosis, there is a cut-off point. So I guess we're still talking about thresholds in a way. And the question is perhaps what identifies that threshold, and perhaps there we might start to say the threshold is defined by impairment or life interference. At what point do those features start to impair a person's life is where you draw the line of saying, okay, this is diagnosis. I agree that it's almost like you're making the assumption that they're different in order to be able to make the argument, and I agree it does start to get rather circular. Yeah.
Just one other quick thing. I mean, so this argument about anxiety disorders are more characterized by impairment than this temperament, I mean, it's problematic because there's a definition of DSM disorders. You have to have distress or impairment there. So sometimes you have impairment, or if you don't have impairment, you're automatically out of the diagnostic. By the way, also, thank you very much for
At least it's made you think, that's true. Look, again, I agree, and yes, I'm not quite sure the answer to that, because I've also sort of thought about that, and I guess then what you're getting back to is that we're not talking about anything different, that we're really talking about exactly the same constructs, and we're drawing a line somewhere which is, say, it's a definitional line that says that there's impairment involved. The impairment issue in DSM is, however, a difficult one, because yes, it is part of the implied definition. It's not in the stated definition. Well, there's some parts of it that's stated, but I'm not sure how well a lot of the diagnostic instruments pick up that statement. And so I guess, yeah, to an extent, I'm not sure it's always adhered to. But you're right, it is part of the definition. Yeah.
It was interesting you were suggesting that interventions had little effect on temperament, improving life skills. So if a person is temperamentally inhibited, there's no way of helping them deal more effectively with stress and challenge. That's what you're saying. I'm sure you can change the way that people with temperament deal with the world, people with high levels of given temperament deal with the world. You're not necessarily, or at least the data at this point is saying you're not necessarily changing the actual temperament. Now that's, as I said, one of our studies showed that you did, and certainly I'm not
I'm not sure I fully believe that. I think a lot of this may have to do with the way that the temperament's measured, because certainly I would have predicted ahead of time that you can shift temperament, and there are some adult studies that show you can shift measures of neuroticism, for example, after treatment. But no, it seems that the data seems to suggest that you don't shift actual temperament, but that you shift that. Certainly, I would think you could shift the way that people with temperament deal with the world, because that then is impairment. Yeah. Yes.
My question is related to that one. Were the interventions in the studies that you showed, were they aimed at social anxiety, adjusting social anxiety, or were they aimed at temperament and measured temperament as well as social anxiety?
That's a good question. The interventions, the first one, the Mortberg study, was clearly aimed at disorder as such, and so that's one of the possible. That's the adult study, and so one of the possible criticisms is that maybe they weren't dealing with neuroticism. Harm avoidance was the temperament they measured in that study. The others, I think the Sheba study was aimed at trying to change difficulty of the child and change the way the parents dealt with difficulty. So I think the Sheba study was aimed at what you might think of as temperament. Our studies were aimed at social, aimed at anxiousness and anxiety disorder, and were aimed at helping the parents deal better with the anxiousness and the fearfulness of the child. So I guess we always thought of it that what we were doing was aiming at temperament as much as at disorder, on the assumption that these are the same thing. And so they were less clearly aimed at purely at a disorder or a symptom-based thing. But they were, I guess they were very traditionally oriented clinical type interventions, which some temperament researchers would argue, well, they are aimed at disorder. So I guess your point being that if you're aiming your treatment at disorder, the fact that you're not shifting temperament is hardly surprising, and that's possible. Yeah. Dina, yeah.
I'm just wondering, it occurs to me maybe there's also a temporal dimension. That temperament, it seems like we all assume, starts very early in life, whereas anxiety disorders can onset not just in childhood. And I'm wondering if there's anybody who thinks that temperament can onset late, or if that would be another difference.
We did grapple a bit with that, about whether you could use age of onset as being a sort of a hypothesis. Rob in particular argued against that. It sort of became a sort of almost a meaningless. I think in general people would say no, temperament is by definition is early, so it became a somewhat meaningless discussion or argument at that point, because it's sort of by definition temperament has to be early, and there's no measures or no studies that we know of that have looked at it starting later or anything like that, because people just never think of looking at that. It's not it's a definitional thing. So it became a sort of a strange argument. Age of onset data for anxiety, though, are variable, and it's a bit of an argument in that way that by definition almost age of onset is beyond early, is beyond preschool or whatever. And again, you find that the sort of more temperament-like disorders, social phobia, generalised anxiety disorder, have the earlier onsets, and many people can't report an age of onset and will say, oh, it's just been there as long, it's forever, as long as I can remember. Whereas panic disorder, in particular, tends to be a very clear onset later on, which again suggests maybe that's a different thing. But social phobia, generalised anxiety do look more temperament-like in that sense of just being a sort of a nebulous thing that's been there forever.